Good morning, everyone, and welcome to this talk entitled Current Concepts in the Treatment of Venous Thromboembolism, and welcome to the conference. I'm Mark Crowther. I'm the chair of the Department of Medicine at McMaster University, and it's a real pleasure to join you here today to talk about current concepts in the treatment of venous thromboembolism. I have a number of disclosures which are listed here. Basically, I have done work for all of the companies that make anticoagulants, and in addition, have done some work with companies that make reversal agents for anticoagulants. So many of these companies will be discussed today, or at least their products will be. I'll try to be as impartial as I possibly can, but I guess there's a potential for bias to always kind of leak into these things. I also hold an endowed chair from Leo Pharma, one of the makers of low molecular weight heparin, and that's held in perpetuity by McMaster University. So there's two questions I'm going to address during today's presentation. The first is, what's the optimal management of provoked and unprovoked deep vein thrombosis and pulmonary embolism? And then the second question is, are there indicators of when anticoagulation can be optimally discontinued in patients with DVT or PE? So what could one do for venous thromboembolism? I started in this business coming up on 30 years ago. It's hard to imagine that I'm that old. And over that time, there's been a landmark shift in the way we manage deep vein thrombosis and pulmonary embolism. When I started, it was unfractionated heparin administered in the hospital, transitioned to warfarin in the hospital with long-term warfarin afterwards. Then came the low molecular weight heparins. And in 2021, where we are now, there's really a number of different strategies you can use to manage acute deep vein thrombosis. You could use a low molecular weight heparin, transition to a vitamin K antagonist like warfarin, IV unfractionated heparin, transition to vitamin K antagonist, subcutaneous unfractionated heparin where appropriate formulations are available, and then the direct oral anticoagulants, rivaroxaban or apixaban by themselves, or dabigatran and edoxaban with an antecedent course of low molecular weight heparins. And there's very strong recommendations around how you should manage DVT in the year 2021 in patients in whom you can access a direct oral anticoagulant. They are recommended as first-line therapy over the combination of low molecular weight heparin followed by warfarin. And that's pretty firm. We do acknowledge that there are a group of patients, certainly in North America and in other countries, who simply can't afford or can't access the direct oral anticoagulants. And if they can't, then obviously low molecular weight heparin, or in fact unfractionated heparin, converted over to warfarin, remains a highly effective but very cumbersome and complex therapy to administer. The preferred treatment in resource-intensive environments where patients can access the drugs is a direct oral anticoagulant, and almost all of us would use rivaroxaban or apixaban because you do not require an antecedent course of low molecular weight heparin. And there's good quality evidence-based guidelines that endorse this. These are from the CHEST guidelines in 2016. There's also the more recent American Society of Hematology guidelines, which would endorse the same thing. When we talk about direct oral anticoagulants for venous thromboembolism, there are things that argue against their use. First of all, they're more expensive than warfarin. They cause at least as much and perhaps more GI bleeding than warfarin. They're more likely to be impacted by non-compliance than with warfarin, because if a patient with warfarin is non-compliant, you know it because their INR starts to fall, whereas with these drugs, you can't tell. They have important but very rare drug-drug interactions, much more rare than with warfarin. They are confusing, meaning people aren't entirely familiar with them yet. They're no more effective than well-controlled warfarin, meaning that warfarin is still a very good medication. And in Ontario, they're not covered by the drug benefits program for more than 6 months. So beyond 6 months, the patient actually either has to pay for them, or you have to transition them to some other therapy, or their third-party coverage would have to cover it. However, they have very strong arguments for their use, and these, in most cases, outweigh the cons. First of all, they're dramatically easier to use than warfarin. They are very simple to use. They're cheaper than low molecular weight heparin, at least in the first couple of days. They are associated with a reduced rate of intracerebral hemorrhage compared with warfarin, and as a result of that, they are associated with a reduced rate of death from bleeding. They're preferred by patients. The patient can take a once daily medication without having to muck around with getting their lab tested. And they greatly simplify the management of acute VTE. And in the era of COVID, which I'll refer to as the plague during the course of the talk, when you have the plague around, patients really don't want to be going for lab testing. So in fact, the DOACs have a huge advantage during the course of COVID. How do these things work? I'm not going to go into this in great detail. The coagulation cascade is the secret handshake of hematologists. If you don't know how to do it, we know you're faking it. And if you do know how to do it, we suspect that you're a hematologist, even if you aren't. Bottom line, factor 10A is an activated coagulation factor, which is located right in the middle of the coagulation cascade. And by inhibiting it, you basically inhibit coagulation being potentiated, continuing along and generating thrombin. and you also inhibit some of the feedback loops. So specific inhibition of factor 10A is a very good therapeutic target. You're also aware of dabigatran, which is an inhibitor of thrombin, which is located further down the coagulation cascade. And you're also aware of warfarin, which inhibit both all of factors 2, 7, 9, and 10. But 10A inhibitors are the principal agents used to treat DVT in the year 2021, and they work right at the center of the coagulation cascade. So we're in this model now where we have a DVT treatment where traditionally it was low molecular weight heparin transitioned to warfarin. Then dabigatran was approved and we had low molecular weight heparin transition to a dabigatran or edoxaban. But in 2021, rivaroxaban or apixaban as single agents are the preferred treatment course for patients. And the package insert will tell you the dosing. Really important to remember that the first 3 weeks of rivaroxaban, the first week of apixaban are at higher than normal doses. Very common medication error to use the wrong dose. You have to familiarize yourself with the package insert and follow those dosing recommendations. And there is no dose reduction in patients with impaired renal function for venous thromboembolism. Use the same dose irrespective of renal function. And if a patient has markedly impaired renal function, you should not be using these agents outside a clinical center that's very experienced with that. A question we get asked all the time is, you're a family physician working in a community in Canada or elsewhere, the patient shows up with a big sore swollen leg, you have a high clinical suspicion of venous thromboembolism, they have some symptoms of pulmonary embolism. Is it reasonable to treat that patient pending a diagnosis? The answer is absolutely yes. In fact, not doing so exposes the patient to the risk of death. If the pretest probability of deep vein thrombosis or pulmonary embolism is high, then you should get on with treatment. Is there evidence to support this? There absolutely is. Dr. Mike Kovacs, who's in London, Ontario, more than 20 years ago, published this nice paper with one of the residents. They took 128 patients who presented outside regular office hours. 44 of them had a VTE on treatment. All 128 received a therapeutic dose of low molecular weight heparin pending investigations and were discharged home or admitted pending investigations. There were no adverse events. This is a very standard practice. I'm not sure why there's some mystery about this. And in 2021, there's no reason why you couldn't have a patient show up in the emergency department at 7 o'clock at night. Ultrasound isn't available till the next morning. There's no reason why you couldn't send them home with a couple of days of rivaroxaban or apixaban at usual therapeutic doses and get them back for testing on the next day. What does the ACCP say about presumptive testing? So there haven't been any recent recommendations, but the 2012 American College of Chest Physician guidelines would still be the ones that are in force. And they're very specific about this. In patients with a high clinical suspicion of acute VTE, we suggest treatment pending results of diagnostic testing. In patients with an intermediate clinical suspicion, they also suggest treatment pending availability of testing. And in patients with a low pretest probability of VTE, they suggest not treating with parenteral anticoagulants while waiting the results of testing. And there's a variety of different scoring systems you can use to allocate patients to low, intermediate, or high dose. The Well score is one of them. There are others as well that you could use to allocate patients. But suffice it to say that if you had a patient who has a low clinical pretest probability of venous thromboembolism, you don't need to anticoagulate them, but the other categories should be anticoagulated pending the results of testing. A question we get asked all the time is, can we actually use a single tablet for the acute treatment of deep vein thrombosis or pulmonary embolism? Am I, as a treating physician, comfortable taking a patient with acute pulmonary embolism and treating them with a tablet? And the answer to that question is absolutely yes. I'm not sure why people are uncomfortable with this. The largest studies of pulmonary embolism that have ever been done have been done with the direct oral anticoagulants compared to low molecular heparin or other interventions. So there's two studies we're going to talk about in this area, one now, one a bit later. The Einstein DVT study was an open label non-inferiority study of rivaroxaban at the usual therapeutic doses of 15 milligrams twice daily for 3 weeks, followed by 20 milligrams once daily, compared with subcutaneous low molecular weight heparin transition to warfarin. 3,500 patients, half and half split on each of those treatments. And the bottom line was that there were 36 events with rivaroxaban, 51 events with enoxaparin plus vitamin K for a hazard ratio of 0.68, statistically significant at a p-value of 0.001. Confidence intervals did cross 1, but barely. But the bottom line was that oral rivaroxaban was as effective as enoxaparin transition to warfarin for patients with acute deep vein thrombosis. There was a parallel study after 6 months where patients were allocated to rivaroxaban versus placebo. And of course, anybody would guess that the rivaroxaban arm is going to be more effective than placebo for long-term secondary prophylaxis of deep vein thrombosis, and it was. That shouldn't be a surprise. But interestingly enough, the rates of bleeds were not that different. 4 non-fatal major bleeds with rivaroxaban versus none in the placebo arm, which suggests that not only is rivaroxaban highly effective for secondary prevention of recurrent venous thrombosis, but that the risk of bleeding is quite small when you extend the therapy beyond 6 months. Bottom line, rivaroxaban is highly effective for long-term prevention of recurrent VTE with a low major bleeding rate. What about pulmonary embolism? Specific study looking at that, published in The Lancet in 2011, open label randomized non-inferiority study. Acute symptomatic pulmonary embolism identified to be at a low risk of death. I'll talk a bit more about the PESI scoring system a bit later, but classes 1 or 2. They were treated initially as an outpatient or inpatient, and in this case it was low molecular heparin transition to warfarin because the DOACs weren't available, but the same conclusions would be made now with the DOACs. Primary outcome was symptomatic recurrent VTE. There were 344 eligible patients. One of the outpatients versus none of the inpatients had a recurrence, and one patient in each group died. So a large number of patients, and establishes the fact that in low risk patients, you can safely treat patients as an outpatient. What is the PESI score? It's listed here. Basically, it's a numerical scoring system. You add up the numbers. If they have a number less than 66 or 66 to 85, they're class 1 or class 2. So I am 54 years old. If I showed up at 54, with a sore, swollen leg, and I get 54 points for that. I get 10 points for being male, so I get a score of 64. I don't have cancer, heart failure, lung disease. Let's say I'm not tachycardic. My systolic blood pressure is okay, my respiratory is okay, my temp is okay, my mental status is as usual. The audience can judge whether that's altered or not, but I think it's not altered. And the arterial oxygen saturation was reasonable. I'd get 64 points, which would put me in a low risk, and I could be safely treated at home if there was a sufficiently high diagnostic suspicion of acute pulmonary embolism. As a result of this study and others that are along the same line, we've concluded that acute pulmonary embolism does not require in-hospital treatment with IV unfractionated heparin or low molecular heparin transition to warfarin. If hospitalization is felt warranted, you don't need to use IV unfractionated heparin. You can use low molecular heparin, but honestly, you can use a direct oral anticoagulant, and low-risk patients can be treated entirely outside the hospital with a direct oral anticoagulant alone. Are there other choices for the acute treatment of deep vein thrombosis and pulmonary embolism? Absolutely. So apixaban, edoxaban, and others have been studied. This is the apixaban study published in the New England Journal in 2013. So hard to imagine, but coming up on 10 years ago. Primary endpoint in 59 of 2,609 patients with apixaban, 71 of 2,635 in the conventional therapy, and a much lower rate of bleeding with apixaban than the conventional therapy group, about half the rate. And so this study concluded, as did the prior, that apixaban was highly effective and safe for the treatment of acute venous thromboembolism. Both dabigatran and edoxaban have also been demonstrated to be safe and effective in place of warfarin for long-term secondary prophylaxis of VTE. But remember, both these drugs do require an upfront course of low molecular heparin, and I recently did see a patient who had been admitted to the hospital with an acute episode of venous thromboembolism who was treated with edoxaban alone, and that has never been tested in clinical trials and should not be used. Question I get asked all the time, is it wrong to use low molecular heparin transition to vitamin K antagonists in 2021? Can I still do that? Sure, you can, but it's kind of old school, right? It's like saying, well, I like to take the train that's powered by steam because I like the picture rather than the diesel, which is a lot faster, more efficient, and way less complicated to operate. Steam trains are still cool, but they're just not quite as modern as you wish. But in some settings, steam trains may be the only one you've got. Low molecular heparin or unfractionated heparin transition to warfarin is likely to fade away with the passage of time. In all eligible patients, whether you're going to use a low molecular heparin transition to warfarin or a DOAC, outpatient treatment is always preferred over inpatient treatment if it's available and is safe. And remember that IV unfractionated heparin is something that we do hardly anymore. It's very cumbersome and difficult to use, and it's very, very poorly done. You really should be trying to avoid using unfractionated heparin in anybody unless you really need to. Next question is, how long should we be treating these patients with acute deep vein thrombosis for? This is actually a really interesting question that we get asked a lot. It's actually fairly simple. If DVT or PE occurs in the setting of a transient risk factor and that factor is eliminated by 3 months, you can stop at 3 months. Classic example, patient goes skiing, I guess not this year because the ski slopes are closed, breaks their ankle, has open reduction internal fixation. 2 days later is emerged with a big sore swollen leg, have to take the cast off because it's all tight. Ultrasound shows deep vein thrombosis. That patient can be treated for 3 months. Assuming they're back to their usual level of mobility at 3 months, you can stop then. If DVT or PE occurs in the setting of an ongoing risk factor, So, for example, a patient with known cancer and the cancer continues, then that patient should be looking at indefinite duration therapy. If it's cancer associated, you should use indefinite duration therapy. And I ask this question all the time. So the patient's got prostate cancer. They're now 10 years out. They still have prostate cancer. They've been treated for 10 years. Do you need to continue it? Well, theoretically, yes, but you need to talk to the patient. Patients are probably sick and tired of taking an anticoagulant by then. If they got minimal residual disease, you and the patient might agree that you're willing to take a risk of recurrence to get off the anticoagulants. I can tell you that now that we can treat cancer-associated DVT with direct oral anticoagulants highly safely and effectively, that's really changed this. So if the patient's a good candidate for a direct oral anticoagulant in the setting of cancer-associated thrombosis, they should get a direct oral anticoagulant. There still are patients in whom low molecular heparin is preferred. I won't talk about that today, but I can tell you there's whole talks that you can find out on the internet exploring who with cancer-associated DVT should get low molecular heparin versus a direct oral anticoagulant. And whenever a patient's on an anticoagulant, it's a high-risk situation for complications. You should be continuously evaluating the risks and benefits of anticoagulation. What about the patient who has a true idiopathic DVT? So that's a DVT that really came on out of the blue without any identified precipitant that you or anybody else can find. The bottom line here is actually that there's a difference between sexes. For men, most of us now would acknowledge that men have an elevated risk of recurrence, and all men who have a single episode of true idiopathic DVT should probably be treated with indefinite duration therapy. Women have a lower risk, and there was a nice study done by Mark Crowther and colleagues. He was then in Ottawa, he's now at McGill, looking at a prediction rule for women with DVT to see what risk factors would cause you to continue anticoagulants versus stop them. I won't get into that. Let's just say that for a woman who has minimal or no residual symptoms, you can probably treat them for 3 months and then stop, even in the setting of a true idiopathic DVT. If a negative D-dimer done at 4 weeks after anticoagulation is stopped is also helpful. If a patient stops, you bring them back at 4 weeks, their D-dimer is negative. That predicts a long-term low risk of recurrence, and that's a helpful finding. If their D-dimer is positive, you might consider re-anticoagulating them. Patient value and preferences is always going to play an important role in this. You'll have men who come to you at 6 months and say, look, I'm sick and tired of taking these anticoagulants, I'm going to stop. As long as you explain that's associated with a risk of recurrence, that's a reasonable strategy. Make sure you document it. Venous thromboembolism is a common cause of medical legal trouble, and I can tell you as someone who does a lot of CMPA work that you really need to document. In summary, in 2021, in general, men with first idiopathic VTE are treated with indefinite duration anticoagulation and preferably with a low dose of a direct oral anticoagulant. In general, women who are asymptomatic at 3 to 6 months are discontinued. Time for some reflections, just a few remaining slides. So DOAC concerns, what are we concerned about with the direct oral anticoagulants? First of all, there's no specific reversal agent for the 10A inhibitors in Canada, but the risk of death from bleeding with DOACs in the absence of a reversal agent is lower than warfarin, where we have 2 effective reversal agents. If a person bleeds, adhere to the principles of bleeding management, work with thrombosis, IR, GI, or surgery to figure out what to do next. Consider prothrombin complex concentrate for 10A inhibitors. They may work. We don't have evidence whether they do or not. They're unlikely to be harmful. They may work. It's probably worth doing it in patients with major bleeding. And for life-threatening bleeding with dabigatran, we do have a specific reversal agent, which is idarucizumab. Patient takes their apixaban, 3 hours later needs to go to the operating room. It's an emergent surgery. What do? There's no way to reverse the drug. They should go to the OR, be prepared for bleeding, consider stepping, and if the patient starts to bleed, maybe use some prothrombin complex concentrates. If the patient's on dabigatran, they can get preoperative idarucizumab. That's been looked at in a study and is quite well indicated. And if surgery needs to proceed, it always should. Compliance is really important with these drugs. We forget this. Compliance is the major limitations of the direct oral anticoagulants. Patients should be educated, and they should be reiterated to them on frequent basis that deep vein thrombosis and pulmonary embolism is a potentially fatal illness, that they need to be compliant with their medications. Remember that if you miss 2 doses of apixaban, 1 dose of rivaroxaban, you're going to have no detectable anticoagulant effect. Not the case with warfarin, where you can go for days sometimes without actually the anticoagulant effect disappearing. How do you switch from warfarin to a DOAC? Well, there's really complicated algorithms in the package insert. I would encourage you to read the package insert. I like to be simple. If the patient's on warfarin and you're switching to a DOAC, I let the INR decline for 1 or 2 days, and I start therapeutic doses of the direct oral anticoagulant. And I tell patients for a couple of days they're going to be over anticoagulated and they should watch for signs and symptoms of bleeding. If the patient's on a DOAC and you're switching to warfarin, the first question you should ask yourself is why. This should happen almost never. I guess it could. I would overlap for several days to allow the INR to be at or near 2. So maybe 3 to 5 days of warfarin with a DOAC and then switch over. And remember that the DOAC is going to interfere with INR testing. So you should not be testing patients while they're taking both medications because the INR is going to be fictitiously elevated. That's all I had to say today. I'd be happy to enter any questions. And again, I'd like to thank the organizers for inviting me to present here today. And I look forward to having a chat with you with respect to more questions. Thanks very much.